Guest speaker tonight is Dr. Matthew Bolshin, a board-certified podiatric physician and surgeon specializing in diseases and medical conditions of the foot and ankle. He will be leading tonight's session and answering all your questions related to type 1 and foot care. Before I introduce him, I'm going to provide a little background about the session itself, like I always do every month. We would like to emphasize that the information shared at the huddles is not meant to provide any clinical guidance. It's meant to open up a discussion around your personal experiences, as well as to answer your questions. We strongly recommend speaking with your healthcare team first before making any changes in your management. I'd also like to remind everyone that we are videotaping this event like we always do, just because there are a lot of people who can't make this time or day, so they watch the recordings on Spotify or from the website. So to make sure this session runs smoothly, we have two ground rules. Number one is just talk at a time, so just be respectful of one another. And two is if discussion around a specific question goes beyond a reasonable time, I'll give you kind of a warning signal indicating that the person has about 10 seconds to wrap up. So now to introduce our guest speaker, Dr. Matthew Bolshin graduated from podiatric medical school at Barry University in Miami, Florida in 2015. He completed an extensive 3-year residency training program in foot and ankle surgery at Westchester General Hospital in Miami. After residency, he moved to Vancouver and has been in private practice for more than 5 years. Dr. Bolshin is passionate about continuing education and keeping up to date with the latest advancements in podiatric medicine and surgery. He's been able to successfully introduce several wound care and other podiatric advancements in British Columbia. His professional interests include all aspects of surgery, as well as pediatrics. He's particularly interested in sports medicine and is a member, oh my God, you should be the Canucks coach. The Canucks doctor, podiatrist, is a member of Sport Med BC. Dr. Bolshin is board certified by the American Board of Podiatric Medicine and is a fellow of American College of Podiatric Medicine. In his spare time, Dr. Bolshin is an avid sportsman who loves everything to do with hockey. He is also passionate about baseball, fitness, and music. You'll find him working out in the gym or writing and playing music on the piano or saxophone. So I'm going to have Dr. Bolshin, give a little introduction himself, and he's going to start with a short presentation followed by the pre-submitted questions that you've submitted. Like always, and feel free to enter any questions in the chat box. Dr. Bolshin.
All right, so thank you for having me tonight. It's a real honor to be able to do a lecture like this for everybody and just kind of share some of my knowledge and my experience on managing foot care in type 1 diabetics. So I just want to share my screen. I want to make sure I can do this properly. Okay. So is that working? Is it sharing my screen or no? I think there we go. So hold on. Okay, can everybody see this? Okay, let me see if I can make this full screen. There we go. Okay, is this working? All right. So tonight I'm just going to talk really quickly about foot care in a type 1 diabetic. I'm going to try to keep this as short as I can. So about me, as we were saying earlier, I graduated in 2015 from Barry University in Miami, Florida, and I did a 3-year residency in foot and ankle surgery and reconstructive rear foot and ankle surgery at Westchester General Hospital in Miami. And I've been in private practice since 2018. I practice at iHealth MD Medical Center in North Vancouver, and I'm also on staff at Falls Creek Surgery Center in Vancouver. So a couple of things I want to talk about tonight. I just want to give a quick overview about diabetes. I think most people know a lot about this already, so I'll keep that one very brief. Some of the warning signs that we look for, diabetic wounds and treatment. Wounds is a really big thing in diabetics, and we want to make sure that we're treating them correctly. Footwear is a really big thing to make sure that wounds don't develop and things like that stay nice and healthy. Charcot foot is a big complication of diabetes, and I just want to touch on that a little bit. And then some complications to look out for and what we can do for them. So an overview of diabetes, again, I think most people here know this already, but there's type 1 and type 2 diabetes. Type 1 is obviously the focus today. Type 1 is often diagnosed in childhood, and we know that the islets of Langerhans and the pancreas often don't work as well as they should, and so the beta cells don't secrete insulin, right? There's beta cells and alpha cells secreting glucagon, and beta cells secrete insulin, and when they don't do that, the glucose builds up. And type 2 diabetes is insulin resistance, so that those people actually make insulin, but their body is resistant to it. So just a quick overview with this. A healthy pancreas produces insulin because the beta cells are working correctly, and it's able to metabolize glucose correctly. And when you don't do that, when the pancreas does not secrete the insulin, you end up with hyperglycemia, so too much glucose in the blood. So some of the warning signs that we see in diabetics are decreased sensation. Okay, so a lot of times when the blood isn't flowing.
Hello, can you hear me?
Yes.
Oh, oops, sorry.
Okay, I'll move on. So some of the warning signs that we see in diabetes is decreased sensation. That's one of the first things that we see. If you can't feel things in your limb, that's very problematic, because you could be walking around, for example, with a pebble in your shoe and not know it. And if you don't know it, that can become a wound, it can become a real problem, and that can be infected, and it can lead to a lot of complications. So when I do a diabetic exam, one of the first things I do is I ask people, do you ever have things that you can't feel? Can you feel your toes? Can you feel your feet? Do you ever get numbness and tingling, that kind of stuff? And I always test that in the office with what's called a Sims-Weinstein monofilament. It's a little, it looks like a needle, but it's not. And it just allows me to kind of make sure with a light touch that people can feel what I'm doing. And we use what's called a 10-point discrimination test. So cold limbs happen a lot, actually, because a lot of people have poor blood flow with diabetes. That can affect your blood flow, especially when your sugar is out of control. And so that often is a sign that that the blood isn't flowing properly. Callus buildup is another sign of decreased sensation. It shows me there's pressure points on the foot, and those pressure points become calluses and then often become wounds. And so we have to be really careful to make sure that that doesn't happen. And a lot of times we want to take the callus down, we want to shave it down a little bit to make sure that that pressure is not building up in that area. Decreased hair growth is another one. That's one of the first things that happens when the blood flow decreases. Hair is one of the first things to go. And so if you have decreased hair growth where you used to have hair like on your toes, for example, that can be a warning sign. And then foot deformities, sometimes we see arches that collapse. And I'm going to talk a little bit later on about what's called Charcot foot, and we'll see that. So I actually can't see my headings here. Sorry, what does that say at the top? I can't see it on my shared screen.
Diabetic wounds.
All right. I'm not going to be able to read any of these. So diabetic wounds are caused by decreased sensation and a lack of blood flow, like I was saying before. There's three main types of wounds that we see. Okay, we see ischemic ulcers. Ischemic ulcers are basically the blood is not flowing enough. And so some people call that an arterial ulcer. Ischemia meaning lack of blood. They're often dark, punched out lesions, kind of black, and we don't really want to touch those. We actually just want to put some iodine on them, keep them nice and stable, and we need to revascularize that limb, right? Restore the blood flow to make that start to heal. A neuropathic ulcer is different. That's when you can't feel things and you develop a sore because you're not feeling it. You're stepping on something you might not know about. There's pressure points that you're not adequately feeling. And so one of the hallmarks is it develops a callus around the wound, and we can really see that, and it's quite telling for this. A venous stasis ulcer usually happens when the venous blood flow, so your veins are not functioning correctly. You get a lot of swelling in the ankle. The wounds tend to be shallow, irregularly shaped, and they're on the medial or the inside of the ankle. All of these require prompt treatment from a foot care specialist. And I hate to say this, but I do have to talk about this. It may lead to amputations when we don't treat these wounds. So it's very important to see a foot care specialist about this. All right, so I actually touched on this a little bit. I'll just say this very briefly. Ischemic ulcers, we revascularize or restore the blood flow ASAP. And we usually treat them with betadine or iodine dressings. Venous stasis ulcers, we treat with compression because there's swelling in the limb, so we need to compress it to get the swelling out. Debridement, meaning like we usually take a knife and we kind of just cut out all the bad tissue. Same with neuropathic ulcers, we offload them because people aren't feeling them, so we want to get rid of the pressure in those areas, and we debride them as well. Okay. This, again, sorry, my heading, what does it say? I don't know what I'm talking about.
It says footwear.
Footwear, okay. Is there any way that I can do this? Maybe I can move this toolbar at the top. Yes, I can. All right, I can move that to the bottom. All right, problem solved. Oops. Okay, so footwear. Accommodative orthotics is something that we do when people are not feeling their foot, okay? There's two main types of orthotics that we do. We do functional orthotics, which is the kind that most people think about. That's, for example, if somebody has a flat feet, if they have bunions, plantar fasciitis, something like that, we often do a functional orthotic. An accommodative orthotic is different. It's designed to take pressure away from things. We often do this with a plastizote top cover, and I'm going to talk about that in a few minutes. But plastizote is one of the most forgiving materials in the world. It's designed for the diabetic foot, and it's fantastic. It absolutely decreases pressure. We often, in these orthotics, we make cutouts or depressions for bony prominences. Again, if there's a deformity in the foot, if there's a bone that's maybe a little bit too prominent, we can make a cutout there and take the pressure away. It's very effective for stopping wounds in their tracks. And again, we want to reduce deformities. A Darko shoe and a crow boot, I'm going to talk about a little bit later. They're a little bit specific, but a Darko shoe, you can actually see it here. It's the second picture. And this is basically a Darko wound care shoe. And I use this when people have a non-healing pressure ulcer that is not responding to conventional treatment. What we do is we actually cut out some of the layers. We leave the top layer of plastizote, and the other ones, we actually make cuts through them in the shape of the wound and reduce the pressure almost 100%. And it forces the wounds to heal. It's very, very effective. So we talked about this. Accommodative orthotics, again, they reduce pressure in bony prominences. Plastizote, I just want to touch on this very quickly. That's that material that's very soft for diabetics. Technically, what it is closed cross-cell linked polyethylene foam, which I don't expect anyone to remember, myself included. But it's the gold standard material for wound care and diabetic orthotics. I put this on almost every diabetic who has a foot where they're not feeling things. And it is absolutely fantastic for this. So the Darko wound shoe, like I said, I wanted to talk about this very briefly. This is the shoe with the multiple layers. You can see it on the right side. So the right picture I have, again, with the plastizote top cover, and the practitioner, which is me, I make cutouts for the wound, and I can offload it extremely well. And I heal some of the toughest pressure ulcers with this thing. The other one that I want to touch on very quickly is the Peg Assist offloading insoles. These are actually really, really good. And they're so easy to use. So it's the one you can see on the left. What it does is it comes with these little pegs. I don't know if you can see it. They're all like little hexagons, I think. And in the office, we can actually just pull them right out, and it will take the pressure completely off the wound. So we see where the wound is. We have the patient stand on it, and we can just pull that right out, and it's fantastic. It really, really stops this from forming pressure when the patient walks. Charcot foot. Sure, if everybody is familiar with Charcot foot, but I just want to touch on this briefly. So Charcot foot is common in various conditions. You can see it here. So if you look at the picture here, a normal foot has a normal arch, right? The arch goes up. It's lower in the heel, lower in the toes, and then higher in the middle, okay? A Charcot foot is often a midfoot collapse, or we call it a rocker bottom foot. This is common in several conditions. First one being diabetes, of course. Diabetes is probably the most common reason that we see this. And I'll explain this in just a second. Two other conditions, which I really am not going to talk too much about today, are tabes dorsalis and syringomyelia. And those two conditions often also develop a Charcot foot due to the neuropathy. Okay, these are neurological conditions that have a component of neuropathy, and it leads to the Charcot foot. But diabetes is by far the most common cause of this. So a Charcot foot, what it really is a progressive condition that involves weakening of the bones, joints, and soft tissue. You often see that midfoot collapse that you can see kind of in the middle there in that picture. As I said before, it's often associated with neuropathy. So when people can't feel their foot, what ends up happening is you can have fractures and things like that. And most people, when they have a broken bone, they'll feel it, right? And they'll stay off of it. But when you have an insensate foot that you're not feeling, you tend to walk on it. And it can be tiny little microfractures that you might not know about, but it's enough that a normal sensation or a foot with normal sensation, people would feel this and they would know not to walk on it. And this would not happen, but this does happen commonly in diabetics. So you get this rocker bottom foot, we call it, where the arch collapses in the middle. And when you have the rocker bottom foot like this, what happens is you tend to get these bony prominences in the middle of the foot. And so it develops wounds in that area. And these wounds can often be very difficult to treat because a lot of footwear is not designed for this. It's not designed for a Charcot foot. So we often use something called a crow boot, or we do a surgical reconstruction, which I'm going to touch on very briefly in a minute. So a crow boot, I'm not sure if anyone's heard of this, but crow stands for Charcot Restraint Orthotic Walker. And you can see it in the picture here. It's a custom designed boot, and we use this for difficult Charcot cases to make sure that pressure is evenly distributed throughout the foot. The foot is completely supported. It has a rocker bottom sole on this. It's designed to support a diabetic Charcot foot. It's, as I said, it's unique for each patient. It's actually a two-piece construction. So there's two clamshells and they kind of come together with straps. And this boot is designed for walking. It's not a cast or something where you have to stay off of it. It's designed to allow somebody with a Charcot foot to walk effectively. So surgical treatment, this is outside the scope of this lecture, but I just wanted to touch on it because Charcot foot is not something that you necessarily have to live with. It's not the end of the world. It can be fixed. So Charcot foot is often fixed with either internal fixation, meaning we put screws and plates inside the foot, okay? Internal fixation is often done with a technique called beaming. And again, outside the scope of this practice, or sorry, of this lecture, but beaming is basically we put the screws and recreate the medial and lateral columns of the arch. So we can actually bring that arch up. And if you look at the picture there on the left, you can actually see that. So we have a before and after of how we actually restored an arch. And the second way to do this, I wanted a picture that wasn't too zoomed in on this, is an external fixator. So the first one with the screws is internal fixation. The second one is external fixation. And that picture is actually, if you look in the middle, that's me. This is one that I did in my residency on a Charcot foot, and we reconstructed it with an external frame. The complications of diabetes. Decreased blood flow, as we said, is a big one because decreased blood flow leads to a lot of complications, as we can see. Venous insufficiency. Okay, so your veins don't function as well. And when they don't function well, what happens is you get swelling in the lower limbs and discoloration in the legs. And when that happens, it often develops wounds. So it's very important to treat venous insufficiency quickly. Decreased sensation, as we talked about, so peripheral neuropathy, wounds, which we talked about quite a bit, and amputations. These are the main complications that I see in my diabetic patients. Decreased blood flow, some of the ways we treat this, I'm not going to take too long on each one, but diet and exercise can be fantastic for this problem. It often makes it so you don't need medications if it's kind of caught in the early stages. Some of the medications we can use are statins. So if your cholesterol is too high and that's creating the decreased blood flow, sometimes statins are very effective. Diabetes medications, of course, because if we control your blood sugar, often we can control what's happening to your circulation. We can stop some of the bad things from happening. Some of the other ones, like silostazol, is not really relevant as much for this lecture, just because that's used mostly for intermittent claudication. But I wanted to include that because it can be used for decreased blood flow. Same with antiplatelet drugs. And then quickly, when we do have a limb that requires a revascularization, what we often do is either a balloon angioplasty. So we put something into the lumen or the middle of the vessel, and we inflate it, and it pushes all the plaque or the cholesterol to the sides of that vessel. And then we often accompany that with a stent. Sometimes we do a bypass graft as well if the the vessel is completely occluded and we can't really push things to the side. We just simply bypass it. And I always mention that you want to revascularize a limb before you amputate. Very, very important. That's more for doctors, but it's very important to do that. So very quickly, venous insufficiency. I mentioned that we do debridement, so we clean up the wounds, and then we compress it. And the way that we compress it is with either compression socks. That's probably the most common way we do this, because compression socks can be done long term. People put them on at home. You wear them during the day. You take them off at night, and it often gets that swelling out and really solves a lot of this problem. It can also be done with medications too. We also, in the office, when I see cases that really have wounds and things that require a little bit more immediate attention, we do a multi-layer compression dressing. So 2 examples of that are Pro4, which is a 4-layer dressing, or an Uniboot, which is a soft cast. And I apply that usually for a week in the office. Patient wears it for a week, and then they come back and we reassess the wound, and we often do it again. And it works very, very well. So wounds, some of the things we do when you have a diabetic wound, any of the wounds we've talked about, we debride that wound again. So we cut out all the unhealthy tissue, and we have what's called granular tissue. That's what we want to leave, which is healthy, kind of red, beefy tissue. That's what we're looking for. Okay, that's the kind of tissue that will heal. And we often put dressings on it, right? And so we use advanced wound care products. One product that I like, I think I was the first in BC to use it, is Endoform. It's an extracellular collagen matrix. It's 1 step less than grafting a wound, and I do it in the office all the time. It's the easiest thing in the world to do, and it incorporates itself. It looks like a little piece of paper, but it incorporates itself into the wound and is really, really effective. And I've healed some of the toughest wounds with this stuff. And we also use grafts sometimes, or skin substitutes. Sometimes we use a xenograft, or sometimes we use actually the latest technology is amniotic grafts. And the picture you're looking at on the bottom there is an amniotic graft. So these are products that that are made in the laboratory, and they're amniotic. So they're actually made of stem cells, and we apply the stem cell directly into the wound, and it incorporates in and heals the wound. They're very, very effective. And the last thing I wanted to say again is amputations. I'm not going to dwell on amputations too much, but when untreated wounds happen and decreased blood flow happen, it often leads to amputations. And the biggest key that I want to hammer home with this is amputations are often preventable. They're not always preventable, but they often are. Regular foot care by a professional is the best way to prevent amputations. If we can revascularize the limb that is lacking in blood flow, if there's a wound that we can treat before it becomes a problem, or better yet, if there's a callus that's going to become a wound and we can treat it before it becomes a wound, these amputations are often very, very preventable. That's all I have for today. Any questions?
Okay, great. So Dr. Bolshin, I am going to read the questions that were pre-submitted. And as people submit questions in the chat box, I can read those as well. Actually, you know what, since Lozane she has a question, I'll just have this since it's the only one on the chat box. I've heard type 1s are more prone to shoulder injuries. Is the same true of foot injuries or additions such as plantar fasciitis?
That's a great question. Shoulder injuries, I'm not sure. I'll take your word for that. Are diabetics more prone to injuries such as plantar fasciitis? That's a tough answer, to be honest. The answer is yes and no. So diabetics aren't inherently more prone to that just for having diabetes. That definitely does not contribute to it. However, diabetics often have foot deformities like we were talking about before. They often have an insensate foot where they can't feel things. And so that often can contribute to these things. So a lot of people, again, if you have a foot where you're feeling it, you're going to feel an injury, or you're going to have a foot that probably functions a little bit better in many cases, where the arch is in a better position, blood flow is in a better position to heal certain things that may happen. And so I would say the answer in that sense is yes. Some of these things are a little bit more common in diabetics, but not inherently from the diabetes. Does that make sense?
Lizane, do you have any follow-ups to that or any comments of what Dr. Bolshin had just said? Okay, so we'll start with question number 1 from Anonymous. How do you get rid of stubborn warts on the foot?
I love that question. So I spend a lot of my day every day dealing with stubborn warts on the foot. So I consider myself sort of an expert at this. There's a few ways to treat it. So most of us know that warts, in terms of home treatment, there's several options, right? There's salicylic acid, so the Dr. Scholl's products, the compound W, or there's the freeze away products. Now, I don't recommend the freeze away to pretty much anybody. I don't think it works. I think it doesn't actually get cold enough, but particularly for a diabetic, it's very, very dangerous. So I don't recommend that at all. When patients come to me with warts, oftentimes they failed conservative treatments in like in their house, or they haven't, or sometimes they haven't tried it at all. And what I usually use is a medication called cantharidin. Okay, I don't know if everyone's familiar with cantharidin, but cantharidin is basically a blistering agent. It comes from a blister beetle, believe it or not. And what it does is it forms a blister, as you would assume. And the blister is what's effective. We don't actually kill the wart virus. Or warts are caused by an HPV virus, and we don't actually try to kill it. We try basically to exfoliate all the tissue that contains the virus. That's what salicylic acid does, the compound W stuff. It just sloughs the skin off very quickly and tries to shed the virus out. So cantharidin, I find, works better than the traditional liquid nitrogen. Liquid nitrogen, again, is mostly for, it's not to freeze the virus to death. It's to create a blister. It creates a thermal injury that creates that blister. And I find that the cantharidin is quite a bit more effective at that. Now, there's other medications too that we use. Sometimes I use a compound of deoxy-D-glucose combined with cimetidine, which is also very effective. And it's something that I have patients apply at home, usually twice a day. And they just cover it up with some tape, and it absolutely treats the wart. Fudex is another one we use at home, and it works very, very, very well. It's actually an anti-cancer drug and works quite well for warts. And when everything fails, what I do is I actually just excise it. I just honestly cut it right out. And that's usually fairly effective. It's not foolproof, but it is effective.
Okay, whoever submitted that question, if you're on screen, would you like to follow up?
Yeah, I'll come out of Anonymous and follow up. Are those medications, do you get those through the doctor then?
That's a great question. The cantharidin, no. The way that works is I don't actually prescribe that to anybody. I use it in the office. Just like when you go see a family doctor and they use liquid nitrogen treatments, they don't send you home with liquid nitrogen. I just use it in the office. I usually do it every 2 weeks. And it's very, very effective. But warts are actually all different. And so I find that if I'm doing it and we're not getting anywhere with it, I usually change up the treatment after a couple times.
Should I then go to my family doctor and ask for that medication? Because he's been doing the liquid nitrogen.
Yeah, so family doctors often don't use cantharidin. Most don't. And so that's something that I see a lot of patients who have seen their family doctor, they've had liquid nitrogen treatments, it hasn't worked, and they come into me and I say, okay, here's what we've done, here's what we're going to do. The cantharidin is definitely more effective, and I usually take over the care.
Okay, great, thanks.
You're welcome.
Okay, question number 2 from Anonymous. I deal with ingrown toenails from time to time and would like to learn how they are caused and what the best treatment is.
Okay. Ingrown toenails are caused by 2 main things. I get this question actually every day. The first one is improper nail trimming. And so this is key. You need to cut your nails straight across. I can't stress that enough. It's straight across. As you start to curve your nail, what ends up happening is it grows into the skin. So if you can cut it straight across, the chances of that happening, it's still possible, but it's significantly less. The second reason that you get ingrown nails, you don't have as much control over. It's basically a genetic incurvation of your nails. So there's a condition called onychocryptosis. I don't expect people to remember that, but it's the nail bed itself is actually curved like that, and the nail grows around it. And so it has a high propensity to grow into the skin. People who have that, it's even more important to cut your nails straight across. Sometimes, though, people can do anything, or they can do everything that you're supposed to do, and we still have an ingrown nail. And when that happens, I usually do a minor procedure in the office. It's called a partial matrixectomy, where I take out 1 or 2 millimeters of nail along the ingrown nail fold, and I put a little chemical into the root, and the chemical kills the root in that spot, and the ingrown nail is gone, hopefully forever. It's usually 95 to 97% effective.
Okay, would that person like to follow up if you're on screen? Okay, question number 3 from Anonymous. What is your recommended foot cream for dry feet?
Okay, recommended foot cream for dry feet, I would say over the counter is Lubriderm. I think Lubriderm works really, really well, but also we have to remember that sometimes it's not just dry feet. Sometimes people are talking about cracked heels, callousing that's often accompanied with dry feet. And when that's the case, it's actually Urea 40% that I like. So the Urosec 40 is a very, very good one if you have dry, cracked skin, things like that. If you have just dryness, Lubriderm is really, really good over the counter. If it doesn't do enough, I usually prescribe people something called ammonium lactate. And that's a prescription lubricant, and it's very, very effective.
Okay, the person who submitted that question, would you like to follow up? Okay, next question from Anonymous. How should corns and calluses be treated on a person with T1D in terms of on their foot? And how, I'll ask the first part and then the second part later.
Okay. Corns should be treated by a foot care professional. I see a lot of patients who have a corn or have a callus, and they've done what we call bathroom surgery. And I always caution against that, because the diabetic foot, more than a non-diabetic foot, is very susceptible to wounds. It's very susceptible to, when you cut the skin, it's not going to heal. And so it's very, very important to have a professional do it. So I see people all the time, diabetics and non-diabetics, who come in with corns and calluses, and I treat them in the office. I shave them down, and sometimes we apply urea cream afterwards to try to keep them down between visits. But it's important not to do it on your own.
Okay, and the second part of the question was, how safe are pedicures?
Pedicures, I don't recommend them to any of my patients. There's several reasons for that. For non-diabetics, the problem with pedicures is they often don't sterilize their instruments correctly. And so when that happens, a lot of my patients come away from their appointment with fungus. So they often develop nail fungus, athlete's foot, things like that from pedicures. On a type 1 diabetic foot, that's actually even more important, because number one, you'd be a little bit more susceptible to getting fungal nails and athlete's foot. But more than that, when they try to shave down calluses and corns and things like that they try to do at pedicure places, they might cut your foot. They're not trained professionals in this. And so I've seen several encounters where this happens, and it leads to a complication that I feel was preventable had the patient come to an actual professional. So for that reason, I have trouble recommending pedicures.
Okay, the person who submitted those 2 questions, would you like to follow up? Okay, the next question is from Dia. Why does my feet sometimes start cracking and peeling when my blood sugars have been balanced? And any signs to watch out for in diabetes care that make the feet worse?
Great question. So often the cracking and sort of dryness and cracking, that was the question?
Yeah, why does my feet sometimes start cracking and peeling when my blood sugars have been balanced? So they're stable. That's the first part.
There's a lot of reasons you can have dryness and cracking on the feet. Certainly if you're bathing in hot water is extremely drying. So that has nothing to do with blood sugar. A lot of times people without diabetes come in and they have really dry skin. And one of my first questions is, are you taking hot showers or are you taking warm showers? Because that can definitely contribute to it. There's other things as well. Dry, cracking, or peeling skin sometimes is a sign of athlete's foot, and that can be another reason. And so a lot of times it's very important to see a foot care specialist about something like that to see what the cause is. I don't want to give a blanket statement and say this is definitely the cause, but if your blood sugar is under control, sometimes we have to think about some of those other things. Whether it's just taking a quick skin scraping in the office and sending it to the lab, checking for fungus, or using some urea cream, usually under occlusion. And that's what I do sometimes when we have really dry, cracked skin. We use some urea cream, the same Urosec 40 that I was talking about, and we apply some saran wrap to the foot. We usually do this once a day at nighttime, and that will drive the medication into the skin and stop that from happening. And I've healed some of the craziest calluses that you've ever seen by doing things like that. Very effective.
Okay, so the second part of that question was any signs to watch out for in diabetes care that make the feet worse?
There's a lot of things to watch out for in diabetes foot care. And I think a lot of them were some of the things I touched on in the lecture. So really, really want to make sure you're checking your feet every single day. I cannot stress that enough. I tell every diabetic who walks in my door, I need you to take a look at your feet every single day. And it doesn't have to be hard. Just take a look, usually at the bottom of your foot, look for new calluses, new sores, new wounds, something that wasn't there before, or something that doesn't look right. If that happens, if you see something, I tell everybody there is no such thing as a stupid question when it comes to your health. Come in, ask me or ask your foot care professional, whoever's treating you, ask them the question and make sure, because I tell everybody, I would rather tell you that don't worry, it's nothing versus it's something and you didn't ask. So that's the main thing I want you to look for, but also decreased sensation, right? If you can't feel things, that's a problem. If your feet are suddenly cold, that's a problem. They used to be warm and now they're always cold. We should get that checked out. If there's new swelling in your feet, if there's decreased hair growth in your toes and in your feet, things like that. These are things you want to look for.
Okay, Dia, would you like to follow up if you're on screen? Okay, I noticed that Narm's hand is raised. Would you like to jump in, Narm? Just because.
Yeah. I'm sorry I'm late. I guess I didn't get the link, so I missed out quite a bit. And oh, it's such an interesting session. I've already learned so much already, so thank you for that. When I go for my treatment, my toe on the side, I have ingrown toenail, right? So they would kind of scrap the line on the right side of my toe, right? And it would be sore. And even right now, I touched it and it's a bit sore. Is that something that I should be concerned about? Because they would just kind of remove the extra skin, the whole line of extra skin on the right of my toe.
So that's a great question, and thank you for that. What I would normally do for somebody who has ingrown nails is I would just do a quick procedure on it, honestly, especially in a diabetic, because an ingrown nail often becomes what's called a paronychia. A paronychia is an infected ingrown nail. That's the kind where we often see like pus coming out of it. It looks really red and angry and that kind of stuff. And any ingrown nail can become that. So what we want to do is stop that again before it happens, or if it happens, treat it promptly. So I think a lot of people, what they try to do is cut out the corners, and you can do that. But the problem is it doesn't really get to the actual issue. So what I do is I just do a minor procedure in the office. I freeze the toe, I cut it straight back on the side where the ingrown nail is. I take out that piece, usually 1 or 2 millimeters of nail, and I put a chemical into the root. And that chemical kills the root in just that spot. Again, 95 to 97% effective. And the ingrown nail often does not come back. And that prevents the infection from happening even before it happens. So that's the best thing you can do for an ingrown nail. Just do the procedure, knock it out, and never look back.
Thank you so much. That was helpful. I'll follow up on that. Thank you. Can I get an appointment? I'm in Toronto. Can I fly to Vancouver?
Oh, you're in Toronto.
I do have some colleagues in Toronto that I would recommend.
Okay, so I guess you'll pass it on to Tricia, and then she'll send it to me on
Yes,
WhatsApp.
we'll go ahead and post it on the Huddle website. And Dr. Bolshin, if you don't mind, we'd be happy to post your practice on our kind of recommended providers page.
I would really appreciate that. Thank you.
Okay, great. So I'm going to finish reading the pre-submitted questions because usually that's the protocol, and then answer questions that people have their hand raised. Anonymous, I have a fractured right foot. Any advice for healing as a type 1?
Great question. So this is actually a lot of what I was talking about. With a fractured foot in a diabetic, and any fracture really, sometimes the blood flow again is decreased and it's harder to heal that fracture. So it's hard to say exactly the situation with the person who posed the question being anonymous, but I wonder if that's a chronic fracture that's been difficult to heal. Now, what we do sometimes is it depends how long it's been, right? If it's just an acute fracture, it should hopefully heal the way any other fracture heals, right? We put it in a cast or a boot, we offload it, that kind of stuff, and the fracture will often heal. Now, if the fracture doesn't heal, we need to know why, okay? If it takes like 6 months, we consider that to be a non-union, meaning the bone didn't join together properly. What we do in that case, I do a lot of what's called exogen. Exogen is a bone stimulator. It's the easiest thing in the world to use. Most of my patients can't even believe how easy it is. All you do is, it's a little device, it's ultrasound. You strap it on over the fracture and you use it for 20 minutes a day. That's it. You barely even feel that it's on. And what it does is it upregulates the growth factors. So all the things in your blood that heal the bones, it actually works to increase them naturally with ultrasound. And it's very effective for healing stubborn fractures or non-unions. But I think in this case, without a little bit more information, it's hard to give specifics, but that's what I do for fractures that are not healing.
Okay, the person who submitted that, would you like to follow up if you're present? Okay, the next question is from Stephanie Hendy. Hi, Stephanie. I've always had foot cramping, but it seems to be happening more frequently now, and I haven't noticed any glucose hydration or nutrition trends. Is there any possible solutions?
That's a tough one. So foot cramping is often caused by, again, decreased blood flow, possibly. Sometimes neuropathy, possibly. Hard to say exactly without examining you. But a lot of times if we can get that stuff under control, we often can solve the cramping, but sometimes the cramping can be caused by a deformity. Maybe there's an underlying flat foot, maybe there's something else going on. So I think it's difficult to give a specific answer on that one without seeing the foot and seeing exactly what's happening and knowing your whole medical history. But the most common causes, like I said, are blood flow and sensation. And so if we can stop those and put them where they're supposed to be, the cramping often resolves.
Stephanie, would you like to follow up on that question?
No, I actually, I started a foot and ankle mobility routine that I found online, and that's actually been reducing a lot of the cramping. So I think it was just the way that I was sleeping, or just the fact that I'm quite physically active, that, you know, wake up in the morning and you're like, oh man. So I might just not, yeah, I think I honestly think doing a mobility routine now, like before I go running or before I go cross country skiing, that seems to be helping, because I noticed that only since submitting the question did I start doing this, and then I found that it was providing some relief. So I think I answered my own question that it was really just muscular tightness, because we don't really do any deliberate exercises for our calves and shins, and then we spend all of our time when we're physically active, we're using our lower body most of the time, right? So it's like all that force goes through that part of the leg, and then we don't spend any time devoted to our lower leg flexibility and strength. And so sometimes it just means that the weakest link, the foot, is going to feel it.
So let me touch on what Stephanie just said just really quickly. You're absolutely right that a lot of people don't stretch their calves, and the calves are actually, they're tight in a lot of people, and this causes a lot of problems. And I see this not just in my diabetics, but I see this in a lot of people who are very active, people who sometimes are overweight. That's not everybody, but certainly that contributes to it. Those are the two main times I really see it, but I see it a lot. And it often causes heel pain, and it causes Achilles tendon pain. And those things are fixed often with calf stretching. And a lot of people who have those types of pain have it more in the morning when they get out of bed, because that's when everything is the tightest. So I always tell people to stretch before you get out of bed. If you've been sitting for a long period of time, you want to stretch again before you get up. These are really important things to do. And often the way you want to do it, I give people the towel stretch, I call it, which I can't demonstrate on Zoom, but it's basically you wrap a towel or TheraBand around the front of your foot and you keep your knees straight when you do it. All these stretches for your calf should be done with your knees straight, okay? The reason for that is because the calf is made up of two things, the gastrocnemius muscle and the soleus muscle. Now, the gastrocnemius is almost always the problem, and it crosses the knee joint, whereas the soleus does not. So if you straighten your knee while you do your stretches, it targets the gastrocnemius quite a bit more effectively, and it definitely works for this problem. I usually tell people to stretch 3 times a day, hold it for 10 seconds, do it 10 times. So 10 by 10, 3 times a day, and it knocks out a lot of these musculoskeletal types of problems.
That's really great advice and doable. So the second part, or the second question Stephanie had, is I do occasionally get numb toes from standing around at home. It doesn't last very long, but is this doing damage, or when should I be concerned?
Great question. Numbness in itself is not inherently doing damage, but we need to know why it's happening. If it's just occasional, I think we keep an eye on it at this point. We can always investigate further if there's other symptoms that are going with it, right? If there's if the numbness is accompanied with cold limbs or things like that, we can investigate it. If it's just occasional numbness, it may just be that you're on your feet a little bit too much, or your shoes could be a little bit too tight. Sometimes, and I see this in the healthiest of people, they wear a shoe that's too tight and they develop what's called a neuropraxia, which is basically something has been pressing on the nerve. And it's a problem sometimes when you do that, when you have that constant pressure on your toe, for example, the toe will go numb and it can stay numb for a little bit. So numbness like that, that's occasional, is not inherently bad, but if it's happening more and more, or if it's accompanied by something else, I would probably want to investigate it further. Plus, it can be treated.
Okay, the person who asked, oh yeah, Stephanie, did you want to follow up on that?
No, I think I just, you know, like I have a sit to stand desk, so I don't sit or stand for too long, but I think I'm just standing for too long, honestly, you know, because you can't really have like a fatigue mat because you need to be able to roll your office chair over it. And I'm standing on carpet, but I'm also, and this is to my detriment, I'm also barefoot all the time because I always want to feel the floor. I don't really want to wear my, you know, I could stand around in my Birkenstocks and I'm sure that would be much more comfortable, but I try to be barefoot at home as much as possible because I want to feel the floor. I want to feel the floor cold, or I want, you know, I want to maintain my balance, because your proprioception isn't as good if you're wearing a shoe. So if you know, like I feel like home's the safest place for me to be barefoot. I'm not going to be outside getting, you know, an infection. So it's, or run that risk of you know, having my foot get infected, right? So anyway, it's yeah, I think I just need to leave my desk more often to get water or whatever, and actually do a little trot through my house, because it's it doesn't, yeah, it wasn't, you know, it never felt bad. I was just noticing it was happening more often, but I'm also realizing, oh, but I'm also working more. That scaled pretty much linearly. So yeah, it's getting, I think, you know, getting used to a sedentary work style is, I think, for me personally, the most challenging. But yeah, that's I'll have to figure that one out for myself.
All right, thanks, Stephanie. The last pre-submitted question is from Anonymous. Is the tingling in the feet neuropathy? And if so, is it reversible?
Oh, great question. So I can't say for sure if your particular tingling is neuropathy, but usually it is. That's the most common cause of this. Sometimes there's other things like neuromas can create some nerve symptoms when you have an inflamed nerve. You'll get something like that, but generally it's neuropathy. Is it reversible? Yes. Yes, it is. Maybe not 100%, but it absolutely is. So there's several ways to treat neuropathy. I think a lot of people are familiar with treating the symptoms of neuropathy, right? So a lot of people use medications like gabapentin. Sometimes we use tricyclic antidepressants, like amitriptyline, or we can even use Cymbalta, which works quite well, which is an SNRI. It's a type of antidepressant. Sometimes people also use Lyrica, right? So these types of medications work, but they treat the symptoms. We need to treat the cause if we want to really reverse it. So the way that we do this is usually a B vitamin complex has been shown to work quite well. But the main thing that I like to treat the cause is alpha lipoic acid. Okay. I'm not sure if everyone's familiar with this, but it's something you can get in a lot of supplement stores. 600 milligrams of alpha lipoic acid daily is really, really effective for this. It's not instant, but it is effective. And the supplement that I like combines all of this stuff in terms of the B vitamins and the alpha lipoic acid. And it's called Nervive. Okay, they actually advertise on TV. But Nervive, the nerve relief, I think is the one. Very effective. It has the right stuff in it. So it absolutely treats the cause. And if we're dealing with symptoms, we want to treat with some of those medications I mentioned. And the other thing I'm going to say is that in my office, I often use a compounded cream to treat the symptoms. And I do that with the alpha lipoic acid or the Nervive. And the cream has a lot of these medications in it. So we use it's gabapentin, baclofen, amitriptyline, and diclofenac. And it works really well for this. So a lot of my patients, they like it because they don't have to take a pill, right? Not everybody wants pills that have side effects, but it works very well.
Okay, the person who asked that, would you like to follow up? All right, let's get to the questions in the chat box. I have dyshidratic eczema, sometimes with nasty blisters on my feet. Any tips?
Well, for eczema is a tough one. So a lot of times we need to know kind of what's causing it. So eczema often has triggers, right? There's a lot of things, whether it's weather, whether it's stress, things like that can often trigger an eczema. Eczema can be treated with natural medications, creams like colloidal oatmeal, things like that. But the most effective way to treat eczema is generally a steroid. Topical corticosteroids are very effective for that. But the problem is you want to balance out your usage with this. So things like betamethasone that treat exogenous flare-ups, you can use it, but you don't want to use it forever because it does have side effects. It does thin your skin. So a lot of times dermatologists manage these long-standing cases. But the more acute ones that aren't as widespread, I definitely treat it that way.
Okay, the person who posted that, would you like to follow up?
Yeah, thanks, Trisha. The blisters that occur with the eczema, I had one that was kind of painful, and I just wondering specifically with those, like I don't really want to take a steroid cream and put it on my feet all the time, and it's not very often, but just last week the one was quite large and painful and looked pretty bad. So for those, is there anything that you would recommend in particular for putting on the blisters, or is that the oatmeal, the colloidal oatmeal, for example? Is that what you're talking about?
Colloidal oatmeal is a nice soothing medication. It's natural stuff. It's not steroids at all. I find that it makes it feel better, kind of like how calamine lotion makes itchiness and that kind of stuff feel better, and it's not a steroid. So it's helpful for that. I think with the blisters, the biggest thing I would recommend is it's important to try not to pop them. If you do have to pop it, you want to put something on it because a blister is sterile inside, right? So when you pop it, now it has a pathway for an infection to get in. So I usually say you don't have to go crazy with it, but if you end up popping it or if it pops on its own, you want to put some polysporin over it. And then we really need to find out why the blisters are forming. And I think that's kind of the biggest thing I would do is investigate a little bit further and why is it doing this.
Okay, thank you very much.
Okay, this is from Allison. I've had type 1 for 10 years and have just had my first foot exam initiated by my GP. Should I be seeing a podiatrist instead? And if so, how often?
That's a very good question. The answer is probably yes. It depends on what your GP is doing. A lot of times there's certain things that I'm looking for that a GP might miss. And that's not to take anything away from GPs. Many of them are fantastic at this, and I really do trust them. But a lot of times I say when it comes to the team approach, I work with GPs all the time. In fact, in my office, there's like 10 GPs, probably more. And so we have that kind of collaborative team approach. But I find that when it comes to foot and ankle, I'm focused on it. Like this is what I do. And it's worth having a podiatrist on board just because not only am I going to maybe find some things that other doctors won't, but if I find it, I can treat it. So sometimes if there's something that doesn't look quite right, you say, hey, is there like a little bump here? What is it? I'll get an x-ray and I'll read the x-ray myself and I'll say, okay, based on this x-ray, we're going to do this now. Or if there's a little callus or something that isn't quite right, I take it down myself and I recommend treatment. So it is worth having a podiatrist on board for most cases like this.
Did you want to follow up, Allison?
Nope, that's great. Thank you so much. I guess if I go once or twice a year, that should be, or I just go when I have concerns, I guess.
You did ask me about the frequency, so I apologize. I forgot to say
It's
that.
okay.
Usually it's every 6 to 12 months. If there's no complications at all, it's 12 months. So once a year.
Okay, great. Okay, thanks so much. This is all wonderful information. It's great. Thanks.
Okay, we have two last questions right on time. From Julie Larson, how do you treat toenail fungus?
Oh, that's a great question. So the toenail fungus is often difficult to treat. Historically, there was two main ways to treat it: topical medicine and oral medicine. Now, the topical medicine has less side effects, but it's also way less effective. So topical medicine, many of us may have heard of it. It's called Jublia. But Jublia, the problem with it is it doesn't pass through the nail. It does not get through the nail in adequate concentrations to treat fungus in many cases. So the efficacy of Jublia is very low. Now, Lamisil, the pills, works much better. However, the Lamisil can be hard on the liver. So it requires some blood work for me to check your liver to make sure it's nice and healthy before we initiate treatment. And then we check it during treatment. So not everybody wants to do that. And I also have to run a drug interaction check to make sure it's not going to interact with any of the medications you're taking. Historically, we used to have lasers for fungus, but the lasers really don't work. And so we're actually not even allowed to advertise that they work anymore. We have to say that they temporarily remove fungus. So what I've been doing recently in the last few months, I actually introduced this product to BC. It's another thing that I'm the first in BC for this. It's a device out of the UK. It's called Clearanail. And this is something you can look up. I think clearanail.com. And Clearanail, what it does is it's a little device I use in the office. It's a micro drill, okay? And the drill drills tiny little 0.4 millimeter holes in the nail plate. And what that does is it allows the Jublia to work better. It simply can get through now because now it has a pathway to get through. The drill is completely painless to use. It's a smart drill. So what it does is it retracts automatically as it breaks through the nail. Cannot cut your skin. And so that treatment is actually equal efficacy to oral Lamisil without the side effects. So that's how I've started treating it lately, and I've been getting good results with it.
Great. Julie, did you want to follow up? Or is that? Okay. All right. So our last question of the night is Caleb.
Hello. I figured I'd ask rather than try and type it all out. But with the ski season coming up, when it's those colder days, I notice that they're like your feet do get cold and there is some numbness there, which goes away. But in me, it always seems to be a bit more kind of like extreme than what it is for friends with that. It goes away. I haven't had any other issues, but is it harmful to be allowing for that to happen? I'm always trying different socks and I have good ski boots, but that's just something that I've been dealing with. I just wanted to know if it's okay to be allowing for that to happen.
So thank you, Caleb, for the question. And that's actually something that you're right. A lot of people get that numbness when they're skiing, and that happens because your feet are cold. What our bodies do when we're cold is it shunts the circulation a little bit to our core to preserve core heat. So that's a normal phenomenon that's happening. Is it happening a little bit more in you? Possibly, right? Because diabetes can affect blood flow, like I've said. It may not. Is it inherently a concern that it's happening to you? Probably not. It depends if you're healthy enough as it is, probably not. But definitely warm socks. You want to wear some nice thick socks when you're skiing. And you just want to warm up your feet when you're done. So if you're otherwise healthy, I would just keep an eye on it. If it's getting worse and worse, then we're going to take a look at that a little bit more. But the fact that your feet are kind of cold and numb goes with the territory of skiing in many cases.
Great, thank you.
Great. Dr. Bolshin, would you mind staying for another 5 minutes? Because I have two questions that just came in.
Sure, of course.
Perfect. The next one is from Allie Blake. Hey, Allie, haven't seen you in so long. If there's time, actually, do you want to ask Allie yourself?
Sure, I can go ahead.
Go
Uh,
ahead.
Yeah, I was recommended by my acupuncturist to never let my feet get cold. And he said if it means you wear heated socks or use heated insoles. And I do find my feet, my circulation probably isn't great. And I do winter sports as well. And they do get cold in even just going for a walk outside in boots with like thermal liners. So is there any concern about using heated socks or insoles with T1D?
Are these like electrically heated?
Yeah, I haven't bought any yet, but I was starting to look.
Great question. So thank you for the question, Ali. I would say yes. I am actually concerned about that. And the reason is, again, sensation sometimes decreases. And particularly if you're talking about your feet are getting cold, possibly they're getting numb, things like that, you can have this heater on and you're not going to feel it. And it might be too hot and it might burn your feet. And so it's the same thing why we tell people don't go to bed on a heating pad, right? Don't sleep on that. It's the same thing here. I would feel much more comfortable if you were wearing just thick, warm socks, because I know they're not going to do any damage. Whereas the heated ones might do some damage.
Makes sense. Thank you.
Great. Stephanie, does that also answer your question since you had it was in the same category?
Yes, yeah, no, that was the same question. It's yeah, no, I cross country ski, so I can't really layer thick socks in, but I found some wool compression socks which at least seem to do okay. Yeah.
Okay, great. And Julie just popped a question in. Can you recommend a podiatrist in Okanagan in the interior?
The Okanagan, what city in the Okanagan?
That would be the Vernon area.
Vernon.
Hey, Julie, I'm in Vernon too.
I don't know anyone in Vernon. I'm not sure if there is. I know in Kelowna, let me just check. I want to say Neil Brown is there. He's pretty good.
Okay.
Let me just check really quickly on my association website. I'm pretty sure Neil Brown, and I've had some patients who have seen him over the years because I have some people who live or have moved to Kelowna. And so I've heard good things about him. Let me just check really quickly. Sorry, 1 second. So Okanagan, Kelowna, we have, I don't know too many of them. Randy Gerber, I'm not sure. I don't really know him. And there's another one, Kwang Fan. I don't know him, but Greg Lindsay I've heard of, and I think he's pretty good too. But probably Neil Brown. It's probably who I would say.
Sorry, and Peter is asking, do you know someone in Victoria, a podiatrist?
Victoria, yes. Tom Garner is pretty good. Doug Lamb is pretty good. Those are probably the two best. They're at least the two ones I know.
Okay, well, great. I am going to wind this down just because I don't like to go over time. I want to thank Dr. Bolshin so much for such an informative talk. It was kind of like attending a lecture, but also, like answering the specific questions each person has, which is really such a, it doesn't happen often, especially for a topic that isn't talked about a lot. So I think we're so fortunate to have you. So thank you again. And for January's topic, it's going to be Ask Jerry, and it's everything about insurance plans and insurance coverage for diabetes care. I think you all, that's a very popular topic. And those of you who know, Jerry was awarded the Diabetes Educator of the Year, I think about 2 years ago, of all of Canada. So we're also fortunate to have her on our team. Looking forward to having everyone in January. And I will be signing off. And Caleb Pope, my protege, will be stepping in for me while I am out of the country for a year. Great. Thanks again. And thanks for attending. Bye-bye.
Hi, Dr. Bolshin. He left already. That's great. All right.
Thank you for your help, Annie.
Thanks, Herm. Sorry about that. See you.
That's okay. I just want to say if there is presentation and recording, that would be great, but I've sent you
yeah.
an email.